Hello everybody, Dr. Matt Ed. Today we'll talk about heart blocks. We will talk about first degree AV delay, second degree blocks, that includes Mobus type 1, also known as Winky block, Mobus type 2, and 2 to 1 block, and third degree heart block, also known as complete heart block. Before we get into it, I just want to talk about the conduction system as a reminder. So here we have the SA node, sinoatrial node, which starts the firing for the electrical system. It's a light switch, and this signal goes to the left atrium, and then as well as the AV node. So it has to go through all this atrial tissue to get to the AV node. So that is the PR interval, and then from the AV node, it goes down the bundle of His, and from the bundle of His, it separates into the right branch and the left bundle branch, and these are called the Purkinje fibers at the side, which is pretty much the highway for the electrical conduction system for the heart to contract. And also just note that the left bundle branch has a left anterior fascicula and a left posterior fascicula. For first degree heart block, remember normal PR interval is less than 200. So if it's greater than 200, as indicated over here, then that's a first degree block, or we call first degree AV delay. It's just that the signal from the atrial sinus node is delayed when it reaches the AV node. For second degree heart block type 1, Winky block, there's progressive prolongation of the PR interval, and eventually the QRS complex is dropped, meaning that the sinus node fires, but when it reaches the AV node, it doesn't go through, so you lose the QRS complex, and then it resets. So the key here is that when it resets, the PR interval here is less than the PR interval before the drop beat here. In second degree heart block type 2, the PR intervals are fixed. Here you see fixed, and then it all of a sudden just drops. That's because the His bundle and the AV node is diseased, and some of the signals just doesn't get through as a result. And for third degree heart block, the AV node is just completely not going through, not letting the signals pass from the atrium to the ventricle. So the atrial activity does its own thing, and the ventricular activity does its own thing. So when you march it out, the P to P intervals are same, and so are the QRS intervals. They'll be the same, but there will be no association between the atrial activity and the P. Next, we'll talk about 2 to 1 heart blocks, and these are special because if you look at the strip, you can't tell if the PR interval is prolonging, because every other beat you have a drop beat, so it's unable to tell if it's a Mobus type 1 or Mobus type 2. Next, we'll talk about how to determine the level of AV block in a 2 to 1 block. So remember that the block can occur at the AV node, the His bundle, or the bundle branches, as we saw the picture earlier. If it's block in the AV node, it is usually okay, but if it's a block in infranodal, meaning the His bundle branches, that's usually not okay, and the patient will need a pacemaker. So this can be told by looking at the QRS duration. If it's greater than 120 milliseconds, then it suggests that the block is in the bundle branches, since the ventricular activity, those beats from the ventricle are usually Y complex. And if it's less than 120 milliseconds, then it suggests that the signal is coming from the AV node or the His bundle. The AV node is strongly influenced by the autonomic nervous system. Atropine, we can make them exercise, or we can make them hyperventilate, which makes the patient speed up the heart rate, and it improves conduction, then we know that the block is in the AV node. But if it worsens conduction, then the block is in the His bundle or the bundle branches. The reason being that, remember I said the AV node is strongly influenced by the autonomic nervous system. So when you exercise, you actually increase conduction through the AV node, and it also decreases its refractory period. But if the block is already below that, then it's not even going to work, and therefore worsen the conduction, since there will be more SA no firing. Next, we'll talk about the pathophysiology of Mobus type 1. During each depolarization results in the prolongation of the refractory period of the AV node. When an atrial impulse comes through the AV node during the relative refractory period, the impulse will be conducted more slowly, resulting in a prolongation of the PR interval. Eventually, the impulse comes when AV node is in its absolute refractory period, and it will not be conducted. This non-conducted impulse allows time for the AV node to reset, and the cycle continues. And also, increased sympathetic response increases conduction and reduces the refractory period. So that's why exercise, when patients have increased heart rate, it improves Wenckebach. For the pathophysiology of Mobus type 2, the PR interval is constant across before and after the non-conducted atrial beat. So the problem is in the infranodal conduction system, then therefore it's associated with a winding QRS complex, bundle branch block, or fascicular block sometimes. And if more than one P wave is not conducted, this is no longer a Mobus type 2 and is considered a high degree AV block. Thank you for watching. If you thought this video was helpful, please like, subscribe, and look out for my next video.